Welcome to What's New in Rare Gynecologic Cancers, presented by Amanda Nickles-Fader. Dr. Nickles-Fader is Associate Professor for the Johns Hopkins Medicine Department of Gynecology and Obstetrics and the Sidney Kimmel Cancer Center. She is both the Vice Chair of Gynecologic Surgical Operations and the Director of the Center for Rare Gynecologic Cancers at the Johns Hopkins Hospital. We hope you learn a lot in the next hour about the new and exciting advances in treating rare gynecologic cancers. With that, I turn it over to you, Dr. Nickles-Fader.
Thank you so much for inviting me to speak today. It's such an honor to speak at the Ovarian Cancer Research Alliance annual meeting on advancements in rare ovarian cancers. These are my disclosures. I am the principal investigator or co-principal investigator of 2 international rare tumor trials. I have a very strong clinical and research interest in caring for patients with rare gynecologic cancers. And I'm the director of the Center for Rare Gynecologic Cancers at Johns Hopkins and a member of the cooperative group Energy Oncology Rare Tumor Committee. For me, with rare tumor science, has always been personal, and patients have really inspired me to pursue a career in rare cancers. And one of my very first patients as a brand new G1 oncology attending, her name was Erin Rothfuss, and she's allowed me over the years to share her story. And she was diagnosed about 15 years ago with low-grade serous ovarian carcinoma. And at that time, there were really no specific therapies for patients with any rare ovarian cancer, and certainly not for low-grade serous carcinoma. And so she and I worked together, collaborated together on an out-of-the-box approach to her treatment. We also worked with Dr. David Gershenson from MD Anderson Cancer Center and brought together the best rare tumor minds, if you will, to help Erin have the best possible outcome over many years. And so I really want to thank Erin and my many other patients I've had the fortune of caring for and the privilege of collaborating with over the years, so that we can together help improve the science and the medicine for patients with rare diseases. If you take away nothing else from this talk today, what I really want folks listening to know is that we have made tremendous progress in the last decade, and really in the last 2 decades, in our understanding of how to treat rare tumors, the best treatment options for women that lead to the best outcomes, and in the rare tumor molecular science. And really, I would say that the last decade, between 2013 and 2023, has been the decade of rare tumor advances, where we've seen a tremendous amount of innovation fueling breakthroughs for patients with rare cancers. And certainly rare ovarian cancers have, the research there has led the charge. In 2013, the Gynecologic Oncology Group, which is one of the original cooperative groups of all of the institutions in the US that study rare tumors, working with the National Cancer Institute, published our first rare tumor trial. That was a group that was led again by Dr. David Gershenson. And only 5 years later, a subsequent cooperative group, GOG, and then the NRG Oncology group, published the next GYN rare tumor trial, also in ovarian cancer. In 2019, the American Society of Clinical Oncology, or ASCO, which is the largest oncology society in the world, named the progress in treating rare cancers the achievement of the year. And that was also based on rare uterine and ovarian cancer trials in part. And by 2022, 2023, we've seen over 15 practice-changing rare gynecologic cancer trials published, many of those, as you can see here, in the rare tumor space. And the reason why I am a rare tumor researcher, and why I think it's really important that the National Cancer Institute and foundations like the OCRA and others really support the work of rare tumor researchers, is that although the incidence of rare tumor malignancies is only a fraction of the leading cancer types, the aggregate impact on patients, on women, on society is massive. And that's because patients with rare cancers represent 25 to 30% of all survivor populations. their tumors may be more challenging to treat because of differences in the tumors compared to more common cancers. And we know that there are fewer treatment options for patients with rare cancers, simply because it's harder to conduct clinical trials in fewer patients to know what the right answers are in terms of treatment. And so it's so wonderful to see the greater emphasis, the OCRA, the GOG, the NRG Oncology, the SGO, FWC, we're all working together to improve rare tumor science and treatments for women. And when we look at ovarian cancer as a whole, this is a very savvy audience who knows that about 19 to 20,000 new cases will be diagnosed in the US. And there's basically three types of ovarian cancer. Epithelial ovarian cancers that can occur on the surface or cortex of the ovary, stromal cancer that starts from ovarian cells that make hormones, and then germ cell cancers that start in the egg cells. Because I only have a limited time to talk today, I'm going to focus my talk on epithelial ovarian cancers, which constitute the most common type of rare cancers that we see and treat. I'd be very happy, though, separately, offline, to answer questions for any patient with a rare tumor disease if we don't cover your specific diagnosis in this talk. And the big question of, is ovarian cancer a single entity? Well, it's a resounding no. We now know from 2 decades of research that even though historically we have often lumped patients with epithelial ovarian cancers into the same chemotherapy treatment trials, irrespective of their tumor type, we really have come to understand that major differences in the genetic and molecular and tumor biology profiles of patients, the different demographics of patients with rare tumors, and of treatment responses for those really have allowed us to understand that there's a major distinction between these tumor types, and we need to approach them differently in terms of treatment. So splitting them out makes sense to some degree, but we're going to talk about that a little further in terms of how we can split that out potentially even in a better way, in a molecular way, as well as based on the tumor type. And so some of the more common epithelial ovarian cancer types include serous cancers. 75% of all women with ovarian cancer are going to have a high-grade serous or high-grade serous, whereas the low-grade serous tumors constitute about 10%. Those with clear cell and endometrioid cancers occur about 11% of all epithelial ovarian cancer subtypes, and then mucinous cancer rounds this out at about 3%. And just so we can make a distinction here about or define what tumor grade is, basically, when we look at how abnormal the tumor cells look like and or how the tumor tissue looks like under the microscope, we can certainly learn many things about these cells. And so this tumor grade is an indicator of how quickly a tumor is to likely grow or spread, depending upon the growth pattern and the cellular features of the tumor underneath the microscope. And when we look at treatment of low and high grade tumors across time, and we've always used, at least for the last 2 decades, have used the NCCN guidelines. This stands for the National Comprehensive Cancer Network. This is an alliance of academic or comprehensive cancer centers, across the country that are defining what the standards of care are for each type of cancer in men, women, and children. And basically, when we look at the old school NCCN ovarian cancer guidelines, this is back from 2005, sort of see here that it was just very simplistic. Like everybody with all different types of ovarian cancer was sort of lumped into this one category, and everyone was treated the same. And you can see here on the screen that taxane carboplatin or carboplatin paclitaxel was sort of the go-to regimen for everyone who had at least grade 3 early stage or stage 1B or higher cancer. And we even saw, this was in an era where we were still considering whole abdominal radiation to treat ovarian cancer, which we now know chemotherapy is superior, and so we're no longer using that. So this is kind of a yikes moment but it also helps us root us in our understanding of how far we've come in treatment standards. And although carbotaxol is an outstanding drug combination that is used very effectively to treat ovarian cancer, we've learned that there's other ways of doing things. And when we actually looked at the large clinical trials that included women, that sort of lumped everybody with all kinds of ovarian cancers in them, and these are some of the most important larger randomized control trials that have been conducted in the last 2 decades through the GOG, we see that most of these studies were underpowered. I think all of them were underpowered to evaluate what is the best treatment strategies for patients with any rare tumor subtype. And this is just an example here in some of the 5 most important studies of our time in ovarian cancer trials that only about 4 to 14% of patients included were of a low-grade serous diagnosis, as an example. And so that underpowering just basically means that we just didn't have enough patients enrolled in that particular trial of a particular type to know, hey, is the treatment here the best for that particular group of patients? But we've really come a long way in terms of clinical trials and also retrospective and cohort studies for patients with rare tumors. And you can see now, almost 20 years later, how much the NCCN guidelines have evolved. We now have breakout categories for 8 different rare ovarian tumor types and treatment schemas and algorithms for those individual rare tumor types. A lot of this is based on level 2 evidence, which some level 1 evidence or randomized controlled trial data, which is the best level of evidence or best type of study. But level 2 and level 3 evidence also offer very important information for us in terms of how to treat patients. And so this is just an example. If you click on one of those rare tumor links, of this is like the low-grade serous. I study low-grade serous, so I'm going to focus a little bit on that in the talk today. You can see here how the treatment breakout is mapped, and you can see that many more specific therapies are now being indicated for the individual rare tumors. Some of what's driving those changes are a better understanding of the molecular genetic mutations in tumors. And so DNA is, as you all know, is our genetic makeup, made up of chromosomes, which include all of our genes. And those drive everything about us, in terms of, what our cells are predestined to do over time during our lifetime. And so gene mutations can be a permanent change in the DNA sequence that makes up a gene. And mutations can be either inherited and passed along through the generations, and that mutation would be present in all of the cells in our body, or they can be what are called somatic mutations, which just occur in the tumor cells, so sort of spontaneous mutations. And they can affect anywhere from a single DNA building block to a large segment of multiple, genes on a chromosome. And so when a normal cell exists, it normally has a certain life cycle or lifespan, just like humans do. And cells, live and die, and then they replicate themselves in order to continue to function normally and help the host body have a normal lifespan. And so what you can see here is during that replication process, or when the cells divide themselves, they have to copy their DNA exactly. And that is a very complicated process. I consider it like a factory and an assembly line. It has multiple permutations, and that DNA has to be replicated exactly or copied exactly as it was in the original normal cell. But sometimes you can have mutations that can occur in cells from a variety of factors, again, hereditary, environmental factors, spontaneous errors that may occur during the DNA duplication process that may not be fixed along that factory line or assembly line, or may get missed. And so that change in the DNA, that abnormality, can then get propagated to future cells that continue to divide and grow. And that can sometimes lead to uncontrolled proliferation or cancer. We've already talked about the different types of mutations. There's hereditary, which can be inherited from a parent and pass through every cell in the body, or an acquired mutation that occurs. It's an insult to cells sometime during a person's lifetime that can occur, that can lead to, both of those can lead to cancers. just wanted to give a little bit of that background because mutations and gene expression are going to be really important in how we understand the differences in rare tumors. But basically, the hallmark of the rare epithelial ovarian cancer subtypes, most of them, are that many of them are what are called low grade, as we've talked about. And they tend to occur in younger women, can still occur in postmenopausal women, but usually in younger or near postmenopausal women. The same treatments that are effective for high-grade serous ovarian carcinoma may not work as well for those with low-grade carcinomas, including like the mucinous, serous, endometrioid, and clear cell cancers. All of these different subtypes have mutations or receptors expressed that are actionable. What actionable means is we can actually target a specific mutation or protein on the cell with a specific treatment that might help us leverage, an effective response to killing those cancer cells. And so we're going to talk a lot about that. This concept of add back therapies or add-on therapies, which means you start with giving carbotaxol and then add additional treatments to that backbone of the carbotaxol. We see mixed benefit in that in patients with the rare subtypes. We'll talk about that too. And then all of the rare subtypes tend to have a relative platinum resistance or carboplatin resistance. That doesn't mean that some don't respond to carboplatin. And so if you're a patient with a rare cancer who's received carboplatin or paclitaxel, that's totally fine and certainly can be within standard of care. But we know that some patients are going to respond well to carbotaxol with rare tumors and some aren't. And what we're trying to study right now is who those patients are and is carbotaxol really the best therapy in those cases. Let's study some of the differences here between for example, the high-grade serous and the low-grade serous tumors. And here's a table indicating some of those differences. And so not only do they look really different under the microscope, but the low-grade tumors tend to grow much more indolently or slowly. They don't replicate or divide their cells quite as rapidly or often as high-grade tumors. Rapid cell division or replication is a hallmark of cancer, most cancers, and chemotherapy works best on rapidly dividing cells. And so we have to be a little creative in how we treat patients with low-grade tumors because they may not respond as well to that chemotherapy if they're not dividing quickly. The mitotic index, again, is a marker of how quickly those cells are dividing and turning themselves over. And you can see that it's much higher for high-grade than low-grade disease. Chromatin is also a marker of that. And then you see a different mutational profile here. A lot of the high-grade serous tumors have P53 mutations. This is a tumor suppressor gene, whereas we see more KRAS and BRAF mutations. KRAS and BRAF are a very important part of a growth factor signaling cascade within cells that regulate how cells grow and proliferate. And if that process is haywire through mutation, it may allow unregulated cell growth to occur. These low-grade tumors, many of them also are very rich in estrogen and progesterone receptors. And so estrogen and progesterone are two of the most important hormones that our ovaries produce. But these tumors can be stimulated by those types of hormones, similar to patients with breast cancer and some uterine cancers. And so that's something to think about in terms of harnessing treatment strategies. We also see very different precursors between the tumors. The low-grade tumor precursor, or the pre-cancer, if you will, is the serous borderline tumor in most cases, whereas we believe that most high-grade serous precursors don't actually start in the ovary, but start in the fallopian tube as a pre-cancer there. When we look at the clear cell mutational profile, it's also very different than that of the more common high-grade serous ovarian carcinoma. We see a very high concentration of what's called VEGF. This is vascular endothelial growth factor that helps form new blood vessels around tumors. Tumors need blood supply to bring nutrients into them, just like humans do, or any living being. And so this helps, we really see an increase in that in these tumors. We see that they don't often have a P53 mutation. They're often P53 wild type. These tumors tend to be more estrogen progesterone negative, but a high concentration of the tumors are what are called MSI high or microsatellite unstable, which is a vulnerability in the mechanisms that the cell uses to repair its DNA if a mutation occurs. And these types of MS high tumors might be really sensitive to treatment with immunotherapy, which we'll talk about. We also, in some cases, see mutations called like ARID1A and PIK3CA, which again are PIK3CA is important in some of those growth signaling cascades that we talked about. And we sometimes see what's called loss of heterozygosity in these tumors, which can render patients susceptible to PARP inhibitors and other therapies. When we look at the continuum of mucinous tumors also have a very distinct profile. They often derive from the precancerous borderline mucinous tumor. And there's two general types that have been identified, expansal subtype and the infiltrative subtype, which is a little bit more aggressive. And we can see that those KRAS mutations that were prevalent in the low-grade serous tumors, we also see them prevalent across all of these subtypes. But we see the HER2, which is a growth factor receptor that's also really present in a lot of breast and uterine cancers, increases over the different types of the mucinous cancer, with the greatest increase seen in the infiltrative type, as well as P53 abnormal mutations increasing from the pre-cancer to the most aggressive cancer type. So these are also potential opportunities to leverage treatment. Let's take a step back now and look at the role of the conventional or old school chemotherapies. There was this really important article that came out in the New York Times in 2021 that showed that a cancer without chemotherapy is possible. And a growing number of cancer patients, especially those with breast, prostate, and lung cancers, and now we're seeing more with ovarian cancer, which we'll talk about, are being spared some treatment because we're seeing that when we focus on molecular or targeted therapies to focus on some of those mutations or proteins that are expressed in tumors, we may have really excellent success with treating tumors. And I think preventing both over-treatment of cancers, not giving patients more than they need since these treatments are toxic, but also not under-treating them so they do well and go into remission and live as long as possible are really, really important. And so precision medicine, which we're going to talk about for the rest of this time, where we really try to right-size the treatment to the type of tumor and the mutational profile of that tumor, really may be the best way forward to improve outcomes for patients. Let's go back to those NCCN guidelines and National Cancer Institute guidelines. When we look at breast cancer treatment over the last 25 years, we see that 25 years ago, more than 80-90% of patients with breast cancer were being treated with some form of chemotherapy or adjuvant therapy. But an improved understanding of the molecular basis of this disease and development of targeted therapies like aromatase inhibitors and trastuzumab and tumor treatment scoring paradigms really have seen a real shift in the evolution of treatment. And so now we're seeing more and more endocrine therapy, or we also call that hormone therapy, where we're targeting those hormonal type receptors like the estrogen and progesterone receptor. Since a lot of breast cancers do have these positive receptors, we're seeing more and more patients with early stage disease, as well as select patients with advanced or recurrent disease, not being treated with chemotherapy, but rather with endocrine therapies and coupled with targeted therapies as well. Prostate cancer chemotherapy is rarely used. We see also very endocrine receptor rich. This is the androgen receptors that we usually see in these tumors that target more of the male hormones like testosterone. And so observation surgery, radiation, or androgen deprivation therapy are the cornerstones of treatment for prostate cancer. So you're seeing examples here of how in some of the more common cancers in men and women, we're not always using chemotherapy where you think we might be. And so we've started studying this in ovarian cancer as well. There's been several smaller studies in early stage clear cell disease to understand, is chemo necessary for patients with stage 1A, for example, clear cell carcinoma. We really don't know the definitive answer here. So if you've received chemo in this setting, don't fear. We are trying to understand that answer, but there are some studies emerging that show that there might be a subgroup of patients who don't benefit from chemo and do just as well with observation after surgery. Similarly, for mucinous ovarian cancers, this was a wonderful paper published in the New England Journal of Medicine, where we saw that patients with early stage mucinous cancers probably don't need chemotherapy, but those with more advanced stage disease may be the ones that benefit the most. We know that some of the most important factors related to excellent outcomes in the primary setting or newly diagnosed setting for patients are having an excellent surgery, and if you have advanced disease, an optimal debulking, and then a targeted, tailored approach to treatment with rare tumors. This was an analysis that Dr. David Gershenson and I did of one of those important ovarian cancer trials through GOG, which was a very large group, more than 1,000 women with advanced ovarian cancer, and they looked at carbotaxol and then adding things to the carboplatin backbone to see if additional treatments would work. And they didn't find that adding more chemotherapy was helpful. But what we did see in this, these are called Kaplan-Meier survival curves. And what we did see here is that patients who had the most disease removed, and those are indicated by the upper black curves here, had a longer and better survival than those who had a lot of disease left behind, and that the chemotherapy used to treat patients, and specifically with low-grade serous cancer in this particular trial, were not as effective if we left a lot of disease behind at surgery. So it kind of tells us the importance of surgery in this. We also are looking at the role of surgery in HIPEC for patients, for example, with recurrent tumors of all different types, but it might be that those with recurrent mucinous tumors most benefit from the heated intraperitoneal chemotherapy or HIPEC. There was a large group from France, the peritoneal surface oncology malignancies group, that published their work on HIPEC, and they found that it was probably the patients with the mucinous ovarian cancer subtype that benefited the most from the HIPEC treatments. So there's a lot of study going on there. Dr. David Gershenson and I have independently studied with our teams the role of endocrine therapy or aromatase inhibitors like letrozole or anastrozole in patients with low-grade serous carcinoma, since 80 to 90% of these patients express estrogen and progesterone receptors. MD Anderson performed this landmark trial where they gave everyone carbotaxol after surgery and then hormonal maintenance therapy or endocrine therapy with most commonly letrozole. And they found almost a two and a half times doubling of the remission rates or progression-free survival in this population when endocrine therapy was given instead of chemo alone. At our institution at Johns Hopkins and at the Cleveland Clinic, we did a smaller study where we didn't give chemo at all to patients after debulking surgery. We just gave them aromatase inhibitor therapy and found a very reasonable, long progression-free survival or remission period in these patients as well. And so we don't know what the right answer is here, but that led to the design of GY19, which is an energy oncology group that Dr. Gershenson and I lead, where we are randomizing patients with stage 2 through 4 low-grade serous carcinoma or peritoneal carcinomas after surgery to either receiving the carboplatin paclitaxel followed by letrozole maintenance or letrozole alone followed by letrozole maintenance. This trial is open in 8 countries where we are enrolling over 450 patients for this study. We have over 60% of patients enrolled, and we're really hoping to give patients an answer to this in the next couple years about what the role of chemotherapy versus aromatase inhibitor therapy is in the treatment of upfront disease. And so you can see this is one of the first ovarian cancer trials actually that did not include a platinum taxane or carboplatin paclitaxel on one of the treatment arms, and sort of moving away from that sort of add-on clinical trial model in breast cancer. Can we start taking away chemotherapy for some of these patients and really focus in on endocrine therapies and targeted therapies instead? A really important pilot study of neoadjuvant fulvestrant, which is another endocrine therapy, plus abemaciclib, which is a CDK4/6 inhibitor in patients with low-grade serous ovarian cancer, led by Dr. Amir Jaziri and Lauren Cobb at the MD Anderson Cancer Center, is really a groundbreaking pilot study that is helping us understand if a patient can't get upfront surgery because of the disease they have, or they may have other medical factors, is chemo the right way to approach this, or should we be using endocrine and targeted therapies instead? And their initial data conducted in their first 15 patients is really exciting, where they've seen a partial or complete response in 9 patients out of their first 15 patients, and a really high rate of optimal surgery at when they have their debulking surgery. And so this is an ongoing study by this group, and we look forward to hearing more. Dr. Brian Slomovitz and the GOG have really conducted a really exciting study, looking at letrozole with ribociclib, again, another CDK4/6 inhibitor in patients with recurrent low-grade serous carcinoma, those who've already been treated and aren't newly diagnosed, and found a very, very nice response rate in this population as well, leading, this combination to be part of the treatment for recurrent disease. Dr. David Gershenson led a super exciting randomized controlled trial, GOG 281, which was studying the MEK inhibitor, which helps in that cascade, that KRAS, BRAF cascade that we talked about earlier, and compared trametinib alone to physician's choice chemotherapy, and found a significantly improved progression-free survival or improved remission rate in patients who received this drug. And although the trial wasn't powered to look at overall survival, really, compelling, slightly increased survival in the trametinib group, although not, statistically significant. So what I'm showing you here is that there's just a number of regimens that are becoming approved for the use in patients with low-grade serous carcinoma in the upfront and recurrent setting. Taking that one step further, Rachel Grisham, Brad Monk, and others are looking at both MEK inhibitor, as well as adding something to that, and that includes FAK inhibition in this really important trial, because we think that more complete shutdown of tumor growth requires us addressing multiple resistance mechanisms. So you're going to rarely see us using just one treatment strategy. Sometimes you can with trametinib. That study showed an improved survival, progression-free survival, but we might get the best bang for a buck if we combine therapies here. And so this was a really important study where the FDA granted breakthrough designation for the combination of the dual RAF-MEK inhibitor in combination with defactinib, a FAK inhibitor in low-grade serous carcinoma, and has led to development of the RAMP 201 trial, which is looking at a further study of this in patients with recurrent low-grade serous carcinoma. It's also being studied by Dr. Katie Moore and Debbie Richardson at University of Oklahoma, this combination for other rare tumor types as well. Basically, there's a registration-directed study that's ongoing right now where we're hopefully to see more results. Again, chemotherapy in clear cell carcinoma, the role isn't entirely clear. The platinum, there seems to be a little bit more platinum resistance in this tumor type than in the high-grade serous carcinoma types. Cisplatin as well as carboplatin have been used in this setting. There have been several studies looking at adding on other therapies such as bevacizumab, VEGF inhibitor, temsirolimus, an mTOR inhibitor, but we haven't necessarily seen an improved benefit to those add-on strategies. We also have studied tyrosine kinase inhibitors, single agent, again, in clear cell recurrent disease like sunitinib, cabozantinib, and others. And we're not necessarily seeing great response rates with single agent therapy again. But one area where we're very excited about with clear cell carcinoma is the use of checkpoint inhibitor immunotherapy. Again, these tumors, either with combination immunotherapy or single agent immunotherapy, seem to be more sensitive to this type of therapy, which helps augment the patient's own T cell defense and response to tumors. And there's been several different phase 2 studies, particularly in patients with clear cell cancer, demonstrating benefit to either single agent or combination immunotherapy strategies. The phase 2 Peacock trial in 48 patients with recurrent clear cell cancers using pembrolizumab, which is one of the more common immunotherapies used, showed a very nice progression-free survival rate and durable responses in many patients. So more on this, there's a lot more coming with regards to that, and also coupling immunotherapy with targeted therapies like anti-angiogenesis inhibitors. When we look at the mucinous cancers, there's a little bit less data here. GOG-241 was a randomized control trial effort assigning women with more advanced mucinous cancers to receive either carboplatin paclitaxel or a capecitabine and oxaliplatin, which is a regimen used in colon and some gastric cancers, because the mucinous ovarian cancers tend to look more like the colon or the gastric cancers under the microscope. Unfortunately, this trial was slow to accrue and closed preliminarily, and so we didn't get an answer for this. We're going to talk about that a little more in just a second. I want to just mention one more trial here of how you can combine pembrolizumab and epacadostat in recurrent clear cell carcinoma. This is NRG-GY16 trial. And basically, you're looking at an IDO inhibitor with a checkpoint or PD-1 inhibitor in patients with clear cell disease. In this particular group, they found a very nice objective response rate of 21% with a somewhat durable response, and 4 patients had stable disease, and stable disease can be a win too if other treatments aren't working and we can just stabilize the tumor so patients can live their lives. A lot of breast cancer therapies and prostate cancer therapies depend on that, where the tumor might not completely shrink away, but it just kind of is held static and it's not causing harm. And so this is an exciting combo that's being studied further. I'm going to pivot back to the mucinous tumors and say, even though that trial GOG-241 didn't complete enrollment, we did do a retrospective study between the MD Anderson Cancer Center and our center at Johns Hopkins to look at the effect of the gastrointestinal type chemotherapy regimens that we use in colon cancer versus the conventional carbotaxol in patients. And we actually found a significantly improved progression-free and overall survival, when we use the gastrointestinal type chemotherapy regimens. And we will say that this trial was retrospective. It wasn't a prospective clinical trial, and did only have, a handful of patients in it. But it is the best evidence we have right now to support, what do we do in the upfront setting, in addition to some of the high-pick therapy coming out. And so at Johns Hopkins, we tend to treat mucinous cancers with more of the GI regimens. We also take a look and we recommend tumor testing for anyone with a rare cancer or any ovarian cancer, really, so we can best understand what mutation profile your tumors have and we can target them. And when we do that with mucinous tumors, we can see that there's a variety of molecular targets here for which we actually have drugs that we can use. And so I'd be happy to answer questions, offline for anyone who has questions about this. There's a number of clinical trials where some of these agents are being studied. But HER2 in particular, you can use the anti-HER2 agents. Those that are MSI high, you can use immune checkpoint inhibitors. SRC is a non-tyrosine receptor kinase that can be altered in about 20% of mucinous cancers, and we have SRC tyrosine kinases that can be considered. So lots of different potential options here, even though they haven't been fully studied in this particular tumor type. I want to just end by talking about the platform trials in rare ovarian cancer. And one of the best ways forward to potentially study rare tumors, instead of studying each individual rare tumor type as its own trial and then waiting to see the results of those trials before studying the next treatment. One approach to studying rare cancers is to studying multiple different types of cancers at once with who may have this, with patients who may have the same mutation in those cancers, or studying multiple different treatments for a particular rare cancer sort of simultaneously. So you can get more bang for your buck. Some trials combine both of those strategies. And so basically we do what's called biomarker screening. And a lot of our cancers have these molecular differences or biomarkers that we can, and biomarker is basically a molecular target that we can harness to differentiate patients who might benefit from a particular drug that targets that biomarker, if you will. Or a patient with a biomarker just might have greater sensitivity to a particular drug than those who don't have the biomarker. And the Bouquet trial is this very exciting trial that's open in Europe and the United States right now, in which a variety of patients with persistent or recurrent rare epithelial, ovarian, fallopian tube, or peritoneal cancers are studied. So all different kinds of patients, endometrioid, mucinous, low-grade serous, clear cell, you name it. Patients may have received 1 to 4 prior regimens, at least one of which was platinum-based, and had the ability to test their tumor, have a prior tumor specimen to test for a biomarker. And then you can see here, depending on the patient's biomarker, they may get a different type of treatment. So if they have what's called BRAF, KRAS, or NRAS activating mutations, they might get a MEK inhibitor here, cobimetinib. If they have a ERB2 amplification that goes along with the HER2, they might get an antibody drug conjugate for HER2. And then there's some patients that may not have a mutation, and they may get a combination of in this case, an immune therapy and anti-angiogenesis inhibitor with atezolizumab and bevacizumab. This has now been expanded. This trial has been very successful, and it has now been expanded to accept an additional 4 different types of treatments to target 4 additional types of mutations or protein expressions like estrogen receptor mutation, PI3 kinase activating mutations, et cetera. And so this is a really exciting trial that we're looking forward to seeing how we can get more bang for our buck and get answers more quickly to patients about which trials and treatments might most benefit them. So in summary, we've been making major progress in expanding treatments for patients with rare cancers. And this has really been through a better molecular understanding of the disease and utilizing precision-based treatments, not doing a one-size-fits-all therapy, but really understanding how we can target a patient's unique tumor profile to allow her to have a unique response and a better outcome potentially. And we can really look at some really unique and compelling biomarker targets, as we've discussed. The progress we're really trying to understand in treatment and trial design is how can we potentially minimize ineffective cytotoxic or old school chemotherapies? Do all women need carbotaxol? Can some women forego it? How can we maximize add-back therapies, endocrine agents, targeted therapies, and strategic combinations thereof? And we know that 2 often is better than 1, so we can target more mechanisms of tumor resistance. And then how can we develop more platform and adaptive trial designs to allow more women with different types of tumors to enroll in clinical trials? I would please ask for those of you in the audience who may be considering a trial, please do consider enrolling on a clinical trial. We have a lot of data showing that this is the best way to get access to the most state-of-the-art treatments, and is the best way for us to all learn how to, best care for women with and patients with rare cancers. And I really want to thank all of you in the OCRA again, Audra, Sarah, and the team for this very kind invitation. I'd like to thank Dr. David Gershenson, Rachel Gershon, and Brian Slomovitz for sharing some of their slides today and for collaborating with me on some of this research. All of my patients, and especially all those patients who enroll in rare tumor trials and are dealing with a rare tumor diagnosis, we've got you, we're with you, and we look forward to continue to collaborate with you to improve outcomes for women across the world. Thank you so much for your time.